So this actually is timely for a number of reasons, and by all means, I'm happy to sort of take questions as we go, as awkward as that may be. But feel free to interject. I think there'll be some time at the end. I did want to have some discussion about COVID and renal replacement, uh, as well as ECMO. That we are dealing with that actively, and I think it's great we're talking. So this will be a little bit of an overview about physiology, and then we'll actually quickly get into the practical components of this. And I've tailored it primarily to continuous therapies. We'll mention to some extent intermittent as we go. So here's just a case. I think this sort of duplicates what we see a lot. Someone admitted for hypoxia, fairly quickly intubated. And the point I wanted to make, and this is pretty clear both in what we see and what the literature is starting to say, is these people, COVID-19 patients, are not hypotensive on presentation. Historically, if you go into oliguric renal failure, you can find your hypotensive event and find granular casts in the urine. It's so classic and consistent, but these cases are different. We'll talk a little bit about what we think is causing the renal dysfunction in terms of that. So in this case, at least, this person went into renal failure fairly quickly, was in positive fluid balance on a high FiO2, and given oliguria appropriately, was initiated on a continuous dialysis modality. You can see in her case, she was acidotic, borderline hyperkalemic, with both a metabolic and somewhat of a respiratory acidosis. And one of the things we are emphasizing to our fellows, at least, is seeing a respiratory acidosis. Frequently, you guys can't fix it, and recognizing the answer is not just turn up the minute ventilation, but understand with the respiratory disease going on, it's not just reducing CO2 as a quick response. So in terms of renal replacement therapy, this is getting into the prescriptions we see. And for the fellows, we'd urge you to come spend some time on nephrology. I know our fellows really appreciate time in the ICU. One of the things we try and do in that setting is get you guys to sort of see how we write these orders. For a number of reasons. One, I think it's really important. Two, your field thinks it's important. Three, it'll be great for your patients down the road, no matter how involved you are on their continuous modalities. And it sounds like there is variable involvement in renal replacement therapy by intensivists. So in this case, she was started on therapy, as you can see, and we're going to dissect out each of these issues. So the dialysate was flowing at 2.4 liters an hour, 2 potassium bath. QB is blood flow, of course. And this gets into the issues of prescription. So that is driven, the things we can change in terms of those prescriptions are blood flow, dialysate blood flow, ultrafiltration would be UF, and the bath concentration at 2 potassium or 4 potassium, looking at where the potassium is now and the expectation for it to possibly change overnight. It's perfectly reasonable for an otherwise stable patient who has a potassium of 4.8 to be on a 4K bath because, and this is a principle we'll come back to, the blood electrolytes move in the direction of the dialysate fluid. So if you say, okay, this person doesn't have any ischemic tissue, if the potassium is 4.8 now, they should move towards 4K. It makes sense to put them on a 4K bath. And we'll, again, look at that a little bit later. So not unsurprisingly, and this does happen fairly frequently, phosphorus levels started to fall. This is a major issue we deal with. Now, in this case, and this happens frequently, by no means is this ideal, and in fact, most people would feel this would be bad care, but it solves the immediate phosphorus problem. Their dialysate flow rate was reduced to 1.2 liters an hour. We do this a lot to avoid profound hypophosphatemia. Now, what that's doing, well, not a lot. We do this on occasion to avoid profound hypophosphatemia, but we have all of a sudden halved the dose of renal replacement therapy. You would think there'd be major changes in antibiotic dosing with that happening. That is a shortcoming of our system. A big push, I would say, from this talk would be if we keep phosphorus levels up, we don't find ourselves in that position. So I know you guys order them frequently. These people do need to be on daily phosphorus supplements to avoid this. So what I want to do today is talk a little bit about principles in physiology. As I mentioned before, this will be primarily focused on continuous modalities. I'll look at some brief trials and what we define as standard of care in the continuous renal replacement world, at least in terms of what we do. I'll show you what other regions do as well. So that'll get into both mode and prescriptions. We'll talk some about complications and that current issues. And again, I want to sort of leave plenty of time for discussion about that. We'll include how best to provide dialytic therapies for COVID-19 patients. Absolutely an issue we're all thinking about. How to provide it with ECMO patients. And how and when to consider intermittent versus continuous therapies in critically ill subjects. So that'll be the sort of things we move through in the next 45 minutes. So just a little principles, because that is helpful to understanding things. Remember, there's diffusion, convection, and ultrafiltration. And those are the sort of three mechanisms that drive dialysis. Convection and ultrafiltration are exquisitely tied together. So let me just give you a picture for that. On the left is diffusion. And here you can see, and I can never remember, can you see my pointer here? Not sure the WebEx pointer system is.
Yeah, we can see it.
Okay. All right, so here you see our membrane. On one side is blood, and on the other side is dialysate flowing counter current to that. So we have blood and dialysate flowing counter current. In diffusion, you have substances moving from a high concentration gradient to a low concentration gradient, presuming they can get through this membrane. So that's primarily driven by concentration and solute size. If you're small, it's fairly easy to get through, urea being the best example. If you're the size of albumin or some globulins, you can't get through. Red cells cannot get through. Thus, though there's a concentration gradient, they don't move through. So this clears small size particles extremely well. Now the comparison is to convection, and that is illustrated on the right, in where you have the same membrane, same exact filters are put in. Instead of dialysate flowing only on the right side in the blue, instead you have the addition of your replacement fluid, which effectively is dialysate fluid, to the blood, and then through a high pressure clamp, if you will, you have a high hydrostatic pressure in the blood compartment, thus forcing a large amount of this substitution fluid across into your filtrate. So in the right here, the filtrate, you see the same sort of volume fluid. It's just that in convection, or CVVH, as we'll see later on, the fluid comes from this side, whereas in dialysis, it's always on this side of the membrane. And this, really, interestingly enough, seems to be just very much a geographic or country issue about what we prefer. There is evidence that's not particularly clinical, that you'll see more molecule weight substances cleared in your convection or CVH mode than in your CVVHD hemodialysis mode. Now, again, no one's done a study showing particularly clinical benefit in those, but that's what we know. So let's put some numbers on this then. So here we see the sieving coefficient, which is the ability of substances to cross from the blood into the dialysate. And you can see that the size of substances gets close to albumin. So that would be similar to the function of the glomerular basement membrane. And then again, plotted over here, you can see everything below the size of albumin, for the most part, is cleared, and that clearance is proportional to size. So there's going to be a lot more clearance of sodium than uric acid somewhere in the middle and myoglobin at the high end. Interestingly enough, they've tried looking at this as a sort of therapy for myoglobin removal, and that has not shown benefit. So clearance is based on size of substances. Most antibiotics are well dialyzed or cleared easily because of their size, and that tends to be a major issue in dosing or running CRT therapy, is understanding what we're doing with antibiotic dosing and avoiding the not intended but likely underdosing of antibiotics. And that'll be one of the things we talk about in complications. So the modes, so here's the sort of specific issues that we see for CRT are listed here. Of course, we primarily use CVVHD. Europe seems to like CVVH or HF. Some people call it that because of the hemofiltration. And that is the convection principle, whereas CVVHD is the diffusion principle. And again, convection may have better middle molecule weight clearances, but again, not anything proven to be effective. You can run them together, assuming your machines are set up to do so. Benefit of that is unclear because one of the side effects is that you're now giving extremely high doses and your antibiotics clearances are going off the chart. You can, using these machines, run sort of half-day dialysis. You can do it a number of different ways, but effectively you can ramp up your dialysate flow and then use these for 12 hours. And that has been proposed if things really get bad with a fixed amount of CVVHD machines. That is what we would probably do, in fact. You can also take a regular dialysis machine and run it for 12 hours, slow, low efficiency, or extended daily dialysis, where you slow down your pump speeds and dialysate speeds. So let me just put the charts of, so you can see what actually is happening. Here is scuff. So not sure why I set it up to start with scuff, but again, this is no dialysate, just fluid removal. We did this yesterday quite successfully on a patient in the ICU. And what you can see is as blood is taken from the patient, goes through a roller pump and into our dialysis filter, and then it's returned to the patient. A little pressure regulator drives hydrostatic pressure in your filter, and that pressure forces across fluid, obviously non-albumin containing fluid, which leaves the pump as the blood minus that fluid is returned to the body. So you can sort of understand what percent is removed. We're pumping blood flow through here at about 300 milliliters a minute, and we're taking off upwards of, not uncommonly, 200 to 300 milliliters per hour. So 1/60th of the blood then is sort of you're concentrating down only minimally if you look at it that way. Nonetheless, you can get a fair amount of fluid out on that individual in particular. I think we got out 4 to 6 liters by scuff in one day successfully. Now, this does not provide a lot of removal of toxins. You'll see some urea, creatinine, potassium removal, but it's not substantive. This is not dialysis. This is just ultrafiltration for fluid removal. If you want to provide dialysis, this is the mode we most commonly use. And here again, blood's being taken from the patient. A roller pump pushes blood into your filter. Perhaps things are added, heparin, perhaps not. And then that is returned to the patient. Same principle, a pressure clamp sits here. While that is happening, Dialysate flow enters in a countercurrent fashion into your filter and leaves. Again, countercurrent being one of the ways in which you get best clearance through diffusion. So diffusion would be there's a smaller concentration of potassium in your dialysate than the blood. What other things get cleared? So water, urea, creatinine, toxins. All get cleared. The bicarbonate concentration, and I'll show you actually the concentration as listed on a dialysate bag in a moment, is higher in dialysate, so it's actually giving bicarbonate here to the blood. So this would be CVHD, what we do. Now back to that scuff theory, you can clamp this down so that the high hydrostatic pressure in here leads to the effluent, what's leaving the dialyzer being a combination of what you put in and the fluid removal you've ordered through the machine. And a very, what's that?
Oh, sorry.
At a very precise level. So that's important. It's far better than what used to be done. And interestingly, you can see in one of the ECMO models where there's no pump, it's all sort of pressure generated. There is a way to do this in inaccurate sort of scenarios, not ideal, but possible. So that's CVHD. CVH is what's primarily used in Europe and many other countries. It's interesting that we ended up with CVVHD, but here instead, so again, from the patient, we have blood leaving the body, emptying our filter, returning to the patient, return pressure increases the hydrostatic pressure within the filter. Now, and effluent is what leaves the filter. The point that's different here is there's no dialysate entering this other port. Instead, your replacement fluid or dialysate equivalent is added to the blood on the same sort of dose, if you will, that we order dialysate. So that would be about 2,000 milliliters an hour. So added to this blood, and then you take off everything you added plus any additional fluid removal. So the effluent would be 2,200 milliliters an hour if you wanted to remove 200 milliliters an hour and had prescribed a entry of 2,000 milliliters an hour. Now you can put that fluid in prior to your filter, which does reduce your dose modestly, but CVHD is never an area to worry about dose adequacy, or you can put it in after your dialyzer. It does, in small studies, show reduction in clotting if you add it to the filter before, which is not surprising because you're diluting the blood and you're avoiding this concentration that goes on. So in this model, you get a much higher sort of rate of convection because that is your mode of solute clearance. And that's driven again by this high return pressure, blood returning to the patient. So CVVH, not something we do here frequently. We've done it, may have better middle molecule weight clearance, but not understood well. So historically, dialysate has come a long way. 25 years ago or so, it had lactate in it. Commonly, that was not metabolized, particularly by people with liver disease, and it just didn't seem to work as well. We now have bicarbonate-based dialysate solutions, one of which, happy to know, I have picked up. So, but you guys obviously know these big bags that hang in the patient's room. Now they have two sort of sub bags. One is a bicarbonate, the bigger one, and the other is the electrolyte. It is key to mix those, and there are reports of, unfortunately, sometimes those don't get mixed. But when they're mixed, you generate a final concentration of fluid, as seen here if it's a 4K bag. So remember, potassium is 4 milliequivalents a liter. In this one, we also have the 2 milliequivalent per liter bags. The other electrolytes are very similar. Now, we'll come back to this, but notice the bicarbonate level is 35. That's what you get. The sodium level is 140. So blood is going to move in the concentration towards dialysate because all of these substances can undergo diffusion, and that will happen. And that is one of the things we do need to consider in a number of scenarios, and I'll bring those up at the end. But the principle being that whatever the concentration in the blood, as long as it's dialyzable, which for electrolytes they are, it'll move in this direction fairly significantly. So what are the practical aspects of CRT as we move through things? One is dosing, and that's probably the key area. Other complications include clotting. I want to mention briefly poisonings and other aspects. So as we look at dosing, in 2000, a major study was published sort of formalizing the importance of high-dose CVVH. This was a European study, and we took that to mean CVHD as well. And what you can see in the Ronco study was the finding that UF, so now this would be a combination of the dialysate or replacement fluid plus of any ultrafiltration you ordered. So this would be really UF can be taken to be replacement fluid plus UF of 35 was better than 20, and UF of 35 was equivalent to 45. So just putting those in perspective, if you're a 100-kilo person, this will make sense that frequently the orders now are not 3.5 liters an hour of dialysate entering the system. It's more along the lines of 2.5 because these high doses have now been shown not necessarily to be beneficial and potentially even detrimental. So let me show you really the best study right now about that. And that's the VA NIH Acute Renal Failure Trial Network study published in the New England Journal of Medicine about 10 years ago. And over 1,000 subjects were randomized effectively to high or low intensity dialysis, whether it was an intermittent in SLED or a continuous modality. In the continuous modalities was 20 milliliters per kilo per hour or 35. You recognize these two numbers being the lower dose, the sub dose in the Ronco study, or the high dose. And this was driven by the fact that subsequent to Ronco, other studies suggested you did not need that high dose. And again, they were getting intermittent dialysis or CVHD and SLED as their modes. And the outcomes were unbelievable, equivalent, really quite impressive in terms of 60-day mortality. So the therapy was equivalent. Now, if you dive into the data, it's actually somewhat interesting. It gets to, I think, some areas we could probably do better ourselves. But in that study, you see that in their high-intensity group, for intermittent dialysis, they were running people 6 times a week. I personally think 3 times a week intermittent dialysis is not adequate for most acute renal failure patients. There is some literature to support that I'll show you, but they were at least for their intermittent 6 versus 3 times a week. For their CVVHD, remember they prescribed 36 milliliters a minute, and they achieved 36. For low intensity, 21 and 22. So one of the impressive parts of this trial is they got what they prescribed. Which means that if the machine went down for 3 hours, they had a system in place to ramp up dosing to make up for the downtime. And I think we all acknowledge these machines go down for any number of reasons. So they made that up to get to their prescribed dose quite frequently. So the attention to detail in this trial was exquisite. Now, but this low intensity dose does seem to be adequate. So a couple years ago, we actually looked at our own dosing, and we found we were generally prescribing 25 and achieving about 20, which we were satisfied with. And other centers have reported similar findings that there's about a 20% drop between prescribed and achieved 24-hour dosing. Now, for intermittent dialysis, we do actually measure dose in the outpatient world. There's an expectation you get to a dose of 3.6 of this this KT over V value. For acute renal failure in the inpatient world, there's no standardized dose. There's several studies that suggest, though, that we're not achieving adequate dose with 3 times a week dialysis. So what about complications? I wanted to mention clotting and antibiotic clearance. So cefepime, right? If you're putting someone on CVHD, they have to be on cefepime. I think it's part of the order set. I'm sure you're laughing now. I just can't hear that. So what you can see is here are some studies looking at cefepime levels in a number of individuals on CVHD. And whenever you look at CVHD and antibiotic clearance, it is important to understand, is this 20 years ago where the prescriptions were different than what we prescribe, or are they up to date? And this is what we prescribe: blood flow 300, dialysate 2 to 3 liters an hour. That's classic for what we do. So here you can see in doses anywhere from 1 to 2 grams Q12, fairly quickly in this admittedly small study of 6 subjects, they achieved levels below the MIC of 8, which is the horizontal line. And you can sort of get a sense that, 1, there's a lot of variability, but 2, certainly within 12 hours, if not within 8 hours, you're getting below this MIC level. You could say, well, obviously we should be checking cefepime levels, and that would be one great solution that we can't do. I think another practical solution is really dose cefepime for a GFR over 60 or CRT dosing, with Q8 being my preferred dose as opposed to Q12, because I think particularly for larger individuals, you get below this MIC level. Now, part of it is, what's the infection? But I think that's something we should consider. 1 gram Q12, I want to get this message across, is inadequate dosing, in my opinion, for someone on CVHD at fairly high dialysate levels. Now, if we come along and have this dose, we should tell you, and the antibiotics should be modified. That's a lot of work. I think we all recognize that is setting ourselves up for pitfalls for any number of reasons. So vancomycin, similarly, has great clearance on CVVHD. And as a result, we probably underdose that medicine. Here you can see, at least in a retrospective study of 40 subjects, looking at levels tracked after 2 or more doses. And what you can see is at 24 hours, imagine a line right here. Really, I think 1 subject had a level over 15 is how I would interpret that. So, and at 28, none. So if you're trying to achieve high vancomycin levels, one solution is to dose it every 24 hours and check troughs. I think the reactive dosing of giving a dose of vancomycin, checking a level in 24 hours, dosing 6 or 8 hours later, really set yourself up for a period of time where you're probably underdosing. So I would suggest, at a minimum, you give vancomycin every 24 hours. And it probably will need to be a bigger dose than you think because of this same issue, clearance. So what about clotting? This is all of our nemesis. We hear about it. I feel for you guys. It's a big issue. There's a number of issues related to it, and we'll move through these as best we can. Certainly, anticoagulation is one thing to consider. You guys have been quite aggressively, and I think our CRT machines have been functioning better because of this. You have been anticoagulating the COVID patients fairly aggressively. The issue of adequate blood flow, and I've noticed we probably bear most of the responsibility here, makes this worse. So these current CRT machines can generate blood flows over 300 milliliters a minute to 350, and that will reduce clotting. But there is a potential for alarms to go off, and one of the tricks to that is to reduce blood flow. And when you start reducing blood flow, particularly below 300, you will see more clotting. So when I'm rounding and I see, reports of multiple systems clotting, I have to wonder, is blood flow being pushed adequately? And this gets into the issue of whether you're anticoagulant or not. If you put up a new system, a new filter, and you can't get a blood flow of 300, it's not clotting that's going on. It's sadly a line issue, and line adjustment, if that's part of the protocol, is probably what needs to happen, not another new system. It's always unfortunate when several systems are gone through at night when I think it's not the system. So line adequacy, position, and size are sort of the other thing. That's a whole nother talk, and I suspect you guys could give it better than me. So what about citrate anticoagulation? You've probably heard about this. It has been proposed in some guidelines as the best therapy for anticoagulation. That has to do with some small studies showing benefits of this versus true systemic anticoagulation. The reasons are listed. As you can imagine, the bleeding risk is lower, but, and this is the reason we don't do it, if you don't do it consistently, accurately, and I'll show you the schema, and I think you'll understand why it's a problem, you set yourself up for problems. So let me show you how citrate anticoagulation works. So here's arterial input, so blood coming from the patient. You check calcium levels. You have an infusion of citrate, and that infusion needs to be managed as blood flow is adjusted. Now that's already sort of a problem in my view because blood flow gets adjusted fairly quickly, I've noticed. So what does citrate do? It chelates calcium, so the blood flowing through the dialyzer now is hypocalcemic and less prone to clotting because calcium, which is dependent in so many of those clotting cascades, is now at a much lower level. Some of that calcium citrate is removed in your dialysate, but not all of it by any means. So post-filter, you are sampling calcium levels. So you have to regularly check calcium levels. Then, of course, you have calcium infusion tied to the calcium levels that are being obtained post-filter. So, and then finally, I might add that the dialysate is different. It actually has a different calcium level. So you would have a citrate protocol and a non-citrate protocol dialysate. The centers that do this do a lot of it, and they put a lot of work into training people to be familiar with it. I think that is a big undertaking. It really needs to sort of be thought through before you do it, and it's not something you'd want to do in small numbers. So other issues related to CRT, I wanted to bring up this issue of poisoning treatment. So the ideal toxin for removal by dialysis has a low molecular weight. You can see most of these, well, all of these really would fall into that category. Most are not protein bound, and that is one of the reasons they are quite well removed. Salicylates being the probable one exception, but they do have a lower volume of distribution, so that tends to sort of make up for some of that. Issues to understand in acute kidney injury is volume of distribution in an otherwise healthy patient is extremely different when you're critically ill, so that may be something to take into account. But bottom line, CRT is actually fairly good at poisonings, with one caveat. If there's life-threatening sort of toxicities, truly emergent life-threatening, perhaps lithium at very high levels is the best example, you can get a lot more clearance with intermittent dialysis, presuming someone's hemodynamically able to tolerate that. So what does that mean for sort of a poisoning that has that sort of issue? I think a reasonable sort of approach would be several hours of hemodialysis to get the levels down to a sort of more comfortable level, and then either hemo the next day or CRT overnight, but understanding the principle that hemodialysis will clear smaller size particles, whether it's a poison or potassium, at a much higher rate in the first 2 hours than CRT. And that's the reason that if the K is over 9, which we'll sometimes see, really intermittent dialysis is standard of care. CRT would not be standard of care for those type values, presuming someone could handle that therapy selection. So that gets into this issue of intermittent hemodialysis. Does anyone have a question? Yep. Okay. Intermittent dialysis in the ICU.
Doing pretty well.
All right. Okay. There's no definitive evidence. One is better than the other. As you guys have probably picked up, we have some standard indications for CRT. They're as listed, any recent CNS events, concerns for ischemia, and that has to do with a couple things, not just sort of fluid removal on hemo machines. Even if you run someone even, as you do it more rapidly because of the higher dialysate flow rates in intermittent, you do see more hemodynamic instability with your intermittent dialysis machine. So anyone who has acute CNS ischemic events or high ICP, and the high ICP is related to the fairly quick potential to reduce urea in the blood, and consequently, due to further shifts, generate higher ICPs. We prefer the slower, sort of more stable CRT therapy. Again, very much standard of care. If you need a lot of fluid removal, CRT will do it better. So one way to think of this is a typical dialysis treatment in the ICU on intermittent therapy. If you get over 2.5 liters off of them, it's an aggressive ICU intermittent dialysis therapy. So think back to your patients. Most are getting in 2 to 4 liters a day. Now, so standard intermittent therapy is 3 times a week. I think in the ICU patients, we frequently push that to 4 or 5 times a week, but that's still falling behind fairly quickly. So if volume removal is the issue, intermittent, even 5 times a week will not provide adequacy. And it also becomes a purely practical issue. It's hard to sort of stay up with people on the intermittent therapy in terms of volume overload. And then, of course, hemodynamic instability. We've all sort of dialyzed on an intermittent basis people on low doses of pressors, but as those pressor requirements go up, we favor CRT. So other considerations, I already hinted at this. The first couple hours, you'll see much higher clearance rates of the small toxins that could be immediately life-threatening. And then the final issue, and I hinted at this before, is most ICU patients will need over 3 treatments a week. So this is a little bit older data, but what they reported in this interesting study that actually made it into the New England Journal of Medicine was the finding that more aggressive, more frequent dialysis was better in terms of mortality in this 160 prospective subject study than 3 times a week. And their mortality difference was huge. I mean, what is that, a 30% mortality difference? So fairly significant data. But when they analyzed it subsequently, they noted that their KTRV per week was 3.0. You may remember earlier in my talk, the standard outpatient KTRV per week is 3.6. So inpatients probably need more. We don't know that, but we think that. So this really represents underdosing of intermittent therapy and reminds us that acute dialysis, for any number of reasons, catheter flow rates being the best example, treatments cut short for oh so many reasons, is probably underdosing. So a couple solutions. One is recognize that if you want a higher dose, CRT is one option. 2 is more treatment, presuming your system can handle that. So I want to then talk about COVID and ECMO, and then I'll sort of leave some time for questions with a couple other sort of points I can make as well. But to deal with COVID and acute kidney injury in the ICU at least, obviously this is an evolving topic. Everything I read started by saying this is an evolving topic, so I thought I'd be very PC and do that. So here's the epidemiology. You can see acute kidney injury with the classic definition is very common. And nearly 20 to 30% of the ICU patients are requiring renal replacement. That's about arguably double non-COVID patients, so significant. The other interesting finding, in this, back to the case I started with, these people don't walk in profoundly hypotensive. They it's like a different presentation. And they often don't have granular casts in their urine. So we do think there's another pathophysiologic mechanism driving acute kidney injury. The current sort of ideas are listed here. Undoubtedly, ischemia or hypoxia and tubular necrosis are part of this, but the cytokine storm, thrombotic disorders, actual viral invasion have all been proposed as possible mechanisms. I suspect the pulmonary world has the same sort of interest and pursuit. So the observation's also been made that generally these people who we're going to end up putting on dialysis often go into shock later, but not quite as early. Yet renal failure can easily and often presents before shock develops. So we're thinking there's another mechanism at place. It doesn't particularly alter management, but it's something to understand. So management, as you know, my obligatory evolving topic. The recommendations from the American Society of Nephrology dealt with this, and this has not really changed. They point out that CRT is the preferred mode. For the reasons listed, it can manage the volume and metabolic issues. It minimizes healthcare provider exposure. We feel for our hemo nurses who go into these rooms and stay there for 3 hours. I know the ICU nurses often are in the rooms, but I think they aren't in there continuously in a way that the hemo nurses are. So this is one reason that we are strongly in favor of continuing these people on CRT, not until they're discharged, but within reason. So I do want to make that point. If you're running out of CRT machines, it's not unreasonable to run these machines for 12 hours. Remember, if you think about dose of dialysis, we are really excessively dosing these people with CRT. So a 12-hour, even higher dose and switching machines to another person is certainly reasonable. It has been proposed, as well as a couple other models, to sort of manage a surge if that were to happen. Fortunately, Dr. Weisberg's been successful for us in getting more CRT machines, as I think you guys know. So that's allowed us really to run these machines successfully, and I think provide great patient care. And nonetheless, we have people on intermittent dialysis in the ICU. So I don't want to send the message we don't do it. We do. We just sort of think about all these issues as we convert people from CRT to intermittent. One of the things this guidance brings up is the sort of reminder to avoid the hasty adaptation of new protocols. So what can be an example of that? Well, you have a disease with high levels of thrombosis. Let's start a citrate anticoagulation protocol like that. We'll work out the details later. That's a bad idea. So there are too many problems that could develop. It certainly, if you're going to do it, it should be done right. And the other point is aggressive anticoagulation protocols will absolutely be necessary, as I think all of us know. So I wanted to spend some time on ECMO, and then we'll stop. 50% of ECMO patients will require renal replacement therapy. As you guys know, the primary driver for that is volume control. There's some debate about when it should be done. CRT is obviously the primary mode. There's very indirect evidence if you can reduce volume overload, their outcomes are better. That's about all I think I can safely say about the studies to date. The issue of circuit location is very much an active issue. We actually had a conference. Solomon Dawson from our division gave us a conference about 2 months ago, really an excellent overview on this very topic, where he looked at the literature in depth. I'm going to present one of the studies he cited and go from there. So what those options are listed here. So here's a sort of schema on the top of an ECMO circuit. So that would be without dialysis. Then in the middle is implementation of just a filter without pump. So basically you grab blood, in this case pre-pump, and let it go through your filter and then replace it, obviously pre-oxygenator. And that's a principle, by the way, of all ECMO and CRT when linked. Blood return has to be pre-oxygenator, as we'll talk about in a second. But here there's no pump, and consequently there's no alarms. So, it's amazing, but basically they weigh what comes out of this on a scale, and that's how they record fluid removal rates. Yet, because there's no pump and alarms and digital stuff, this seems to actually work in terms of not alarming. The accuracy, I think, in 2020, most of us would say, is inadequate. We can do better than that. And so we try and sort of fit in our CRT machines to this, large amount of moving blood. Appropriately, it is tempting. And so there have been any number of sort of models. Now, this is a nephrology publication that sort of talked about their experience. So they sort of grabbed blood post-pump, pushed it through their CVHD machine, replaced it pre-oxygenator. And I think, but as an alternative, you can grab the blood prior to your blood pump. Now, it's important to understand why problems are occurring when this is happening. So in CVVHD, these pumps are typically, always hooked to venous systems with pressures of 0 to 20 millimeters. So when you now put them onto much higher positive pressure systems, the alarms go off. These machines are quite adequate. And I think we can all quickly appreciate that a CVVHD machine that's alarming in an ICU bed of someone perhaps with a COVID infection is really not ideal, because it would require a nurse to go in and frequently to sort of manually override the pumps, perhaps make adjustments to figure out how the machine could operate best. Blood flow would be reduced. The system would quickly clot at the lower blood flow. Blood flow is reduced, by the way, because that does seem to be one of the quicker and dirty ways to reduce alarming of these systems. So no matter where you hook up, you are going to get exposure to pressures that are far higher than what the CVHD machines are used to, and that's why the alarming occurs. So there is absolutely literature about hooking up in various places. So here's, again, the various options. The inline hemo filter, that was that first thing. Again, not accurate. Doesn't seem like we could do very well. If blood flow is too high, they compress the flows with clamps in a very inaccurate way. The parallel systems require new access, and unfortunately that access would need to be while getting anticoagulation. It brings up the issue of if someone's going for ECMO cannulation and there's any suggestion of renal failure, and you're not running in parallel, running in series, so this would be our current nephrology approach, which is to run in parallel, maybe that is the time to get access. So you don't see your alarms, you don't see your ECMO efficiency drop, and the dreaded air embolus is not occurring because you have parallel systems. So there's a lot of talk about this air embolus. As you're adjusting pressure flows, you could potentially have an air embolus and lose your ECMO system. And that was the description when as part of this conference, we actually got in touch with several centers that run a fair amount of ECMO and CVHD, and they said, particularly at a program that's starting up, you don't want to create a scenario where, because of sort of, fiddling may not be the best choice of words, but you get the idea of moving things around to avoid pump systems, your ECMO system goes down. That would be a tragedy. The other issue that I think is sort of very pertinent to us right now is when hooking up in series. So that would be taking advantage of the blood ports on your ECMO circuit. But I want to reinforce this point, always returning before oxygenator, because otherwise you have the risk of a thrombosis sort of re-entering the circulation. You see these alarms going off. And that right now, I think, would sort of obligate nurses to go in and out of these rooms far too frequently. It would not be a smooth operation. So there's a little data about this very point. So here's a small case series that described in a retrospective way, their attempt to sort of hook series up. And I think, their problems are illustrative of exactly what I just showed you. They did not note any ECMO complications, I will point out. So as you can see, in option 1, the hookup was after the pump input into their CV circuit and then return pre-oxygenator. They got 7 people to actually, of 12, to sort of work through that mechanism. However, 5 didn't work that way. So they required system, takedowns. Now, they didn't go into the details of, did this system clot? What did they lose in that process? But 3 were moved where the blood input to the CVHD machine and then output, as you can see here, were placed in different positions, slightly different risks, the biggest being air embolism, not reported in this study. So, and again, not everyone was managed successfully in that mode. So additionally, 2 more required additional modification to get their lines placed in this sort of schema, both pre-pump. And then 1, this clamp basically is trying to dampen the return pressure out of the CVHD machine to really trick the machine. And you quickly understand that it's the CVHD machines not liking the high pressures of the ECMO circuit that is a problem. So in summary, I'm going to stop and then answer some questions. Obviously, this is a common thing we deal with. Volume management really, I think, is something that's key. And I have to say, I think the ICU and nephrology teams work very well about sort of talking about, hey, I want to take more fluid out of that person. And there's a lot of comfort and respect about opinions, and I think that's great. And I'm happy to see it, and I'd urge people who leave to work hard to sort of keep that relationship up. COVID's infection is significant, and I would imagine or hope that someone is sort of working on figuring out a CVHD machine that doesn't dislike the ECMO pressures that are generated, because it seems like it almost, would be expected. Well, in 50% of people, it is expected. So that would not be unreasonable. So I'm going to stop there and answer any questions. Thank you very much.